Okay, our next topic is cytomegalovirus, also known as CMV. This is a DNA virus. It is a sexually transmitted disease, as you will see as we go on. It is the most common cause of congenital deafness. Now, we talked about congenital deafness as being part of the congenital rubella syndrome. The prevalence of congenital rubella is so low that it is not a significant part of the overall causes. But CMV is very, very prevalent. And here's our case. A 31-year-old neonatal ICU nurse. Now, neonatal ICU nurses are exposed to all kinds of perinatal infections. And one of those is CMV. Now, she had just undergone an uncomplicated spontaneous vaginal delivery of a term baby that weighed 2,300 grams. Term babies should be over 2,500 grams. 2,300 grams, this is clearly small for gestational age. This is IUGR. A term 2,300 gram female neonate with a diffuse petechial rash. Newborn, SGA, IUGR with petechiae, you better think CMV. At 12 weeks gestation, she experienced a flu-like syndrome. This sounds very much like toxoplasmosis, a flu-like syndrome. Now, she had right upper quadrant pain. My suspicion is if you would have obtained some liver function tests, you may very well have seen some elevated liver enzymes because she probably had a CMV hepatitis. Serial obstetrical ultrasounds showed the fetal growth was only at the 5th percentile. So this is clearly a small for gestational age baby, but I want you to particularly notice petechiae. Now, this is the CMV inclusion body that you would see on histology. Cyto, cell, megalo, large cell. Look at this huge cell here. This was initially thought to be a fungal infection, and then subsequently it was found to be a viral infection. This is your CMV. How is it transmitted? It is transmitted by body fluids. That would be urine, blood, saliva, vaginal fluids, semen. Cytomegalovirus is transmitted by body fluids. Residual effect, is it lifelong latency or lifelong immunity? And the tragedy is this is lifelong latency. Once you've got it, you've got it. And it can come back and you can have a recurrence. Now, the transplacental infection rate between a primary infection and a recurrent infection is significant. If there is a primary infection, 50% transplacental infection to the fetus. If it is a recurrence, it's only 1%. Now, how can you explain this huge distinction? It's actually very similar to herpes. The primary herpes transmission rate to the fetus is 50%. And of a recurrence is only 5%. And probably this accounted for by, number one, the viral load is much higher with a primary infection. And secondly, is that you probably have with a recurrent disease IgG antibodies which can cross over the placenta and can provide protection of the fetus. The most common congenital viral infection is CMV. 1% of newborns. Now remember, there were 4 million births in the United States per year. What number of those 4 million babies have congenital CMV? 40,000. 40,000. That's a lot. I also want you to remember, if you have a newborn with petechiae, you should think CMV. Good board question. Neonate with petechiae, CMV. Now, prevention of CMV is universal precautions. And that's true whether we're looking at CMV, we're looking at HIV, or any of the body fluid-borne infections. So, who's going to give it to you? It's going to be the patient who you're not aware of. It's going to be the one who you think is probably okay. We should use protection, glove, double glove. I double glove with all my surgeries, eye protection, and appropriate coverings. So universal precautions to prevent CMV. The treatment, ganciclovir, and that has remained the same for many years. The treatment for CMV, but must confess, I have never diagnosed a known case of primary CMV because it often presents as a flu-like syndrome. The risk of fetal infection from CMV, regardless of the trimester, is high, 50%. Now this is with a primary infection, 50%. So that's pretty high. Remember, if you would, neonatal petechiae, CMV. Neonatal petechiae, intracranial calcifications, symmetrical IUGR. Think congenital CMV. Now remember, with toxoplasmosis, it was chorioretinitis, intracranial calcifications, symmetrical IUGR. So both of these have common findings, but the petechiae is specific for CMV. What percentage of women of reproductive age are IgG CMV seropositive? 50%. 50%. So half of women are CMV positive. Now I should say that the IgG is evidence of a previous infection, and you don't know what the duration is. Typically, the first antibody to go up is your IgM. Typically that goes up, stays up for a week, maybe a month or two, and then goes down. With CMV, the IgM can go up and stay up for up to 2 years. And that makes it very frustrating when you get antibodies, IgG and IgM antibodies, to be able to say, is this a recent infection or is it a distant infection? And that brings us to the end of CMV, cytomegalovirus.